the dose distribution from IMRT and Proton is comparable with regards cardiac sparing. If you have disease, for example, confined to one or the other side of the heart, or if it's entirely superior to the heart. But when you have a situation where you have disease surrounding the heart on both sides, as is shown on the right, there's a clear benefit from using protons. IMRT generally has a hard time keeping the dose low in that scenario. For the lungs, of course, in order to control pneumonitis, it's important to keep the mean dose as well as V20 and V5 low. So given the special nature of protons, there's no exit dose. So we can see here a clear example of when we have disease confined anterior to the heart, we can really significantly spare a dose to the lungs, which is a major benefit. In addition to that, because of the fact that a significantly high percentage of patients who suffer from lymphoma are pediatrics, the leading cause of death for long-term survivors is actually the development of secondary malignancies. So that's particularly important for the breast, given its proximity to the treatment site, and also its radiosensitivity. So these three organs at risk are important to keep in mind, and protons can really help minimize dose to these normal structures. Pencil beam scanning proton therapy is especially beneficial because it provides even greater conformality. With PBS, we can conform the high dose region to both the distal and the proximal boundary of the target, whereas with passive scattering techniques such as double scatter, this is impossible. We can conform only to one or the other of these edges. So we get much greater conformality with PBS. In addition to that, PBS allows for the use of much larger field size. And this is particularly important for treating lymphoma because the target often is quite large. It will often encompass the entire mediastinum and may also encompass the axillary and supraclavicular regions, and in some cases the neck. So with a large field size, we can treat with a single field, and this is really beneficial. It allows us to reduce treatment time and also avoid the need to do field matching, which can be more complicated. So the guidelines set out here recommends the use of respiratory motion management when target motion exceeds 5 millimeters. So in particular, deep inhalation breath hold is the technique which is most often used for treating lymphoma. So there's a wide variety of different systems that can be used for breath hold that make use of different technologies. Probably one of the most widely used are systems that make use of external markers, such as the Varian RPM and RGSC system. These systems are adequate for treating with photon therapy. However, there are some uncertainties associated with these systems that can affect the correlation between the external marker motion and the actual internal tumor motion. For these reasons, spirometer-based systems such as the SDX are often preferred, favored for proton therapy. The reason, of course, is that, as we all know, the dose distribution in proton therapy is extremely sensitive to even slight changes in anatomy and patient alignment. So the potential consequences of this deviation in the correlation between the signal and the tumor motion can be more significant. So spirometry-based systems are used in many proton centers. And of course, we use the SDX here at Inova. We use RPM and RGSC for our Proton treatment, but SDX for Proton. Okay, so just a quick outline. So I'll first just give an overview of our Proton Center and then describe the SDX system that we use. Then I'll walk through our clinical workflow step by step, followed by taking a closer look at one particular lymphoma case that was particularly interesting. Okay, so our Proton Therapy Center is located at the Inova Schar Cancer Institute in Fairfax, Virginia. It's a comprehensive cancer care facility. We have everything under one roof. We have a very broad range of different treatment modalities, including photon external beam, as well as CyberKnife radiosurgery, LDR and HDR, brachytherapy, IORT, etc., and of course, protons. So the system that we're using is the IBA Proteus Plus. We have 2 gantries with dedicated PBS nozzles. The center has been open since March of 2020, and to date we've treated close to 250 patients. In addition, we're participating in several proton clinical trials, including the PCG registry, Compare for prostate, and RadComp for breast. You can see on the right a breakdown of the different sites that we treat. So the leader is head and neck, followed by chest wall and breast, and then brain and pelvis and prostate. Okay, so an overview of the SDX system. The SDX respiratory gating system makes use of spirometry, so it measures the patient's breathing and correlates that to change in lung volume. So on the top right, you see an image of the system. The patient breathes into a mouthpiece, and a sensor measures the breathing, and then it displays this on a screen, which is shown on the bottom right. So this screen, of course, is displayed in the console for the therapist, but also it's displayed directly to the patient via the video goggles, which you can see on the top right. So this is one of the unique features of SDX that we don't have in every breath hold system. For example, our RPM RGSC system that we use for photon treatment doesn't have this feature, and so we rely on verbal coaching from the therapists to get the patient into a proper position. Okay, and of course, a key feature of SDX together with our Proton system is that they're integrated such that we have automatic beam control or gating, so that our Proton system is configured to only allow beam on when the breathing signal shown in red falls within the breath hold window shown in green on the bottom right. And this breath hold window is, of course, measured during simulation for a given patient. Okay, so our workflow is based on a moderate deep inhalation breath hold, or MDIBH workflow. It's described in detail in this publication here. And the goal is to achieve a highly robust treatment plan by making use of multiple MDIBH scans. So this diagram here shows the workflow in 3 steps. So in simulation, in addition to the nominal breath hold scan, which we use for treatment planning, we take 2 additional CT scans at slightly higher and slightly lower breath hold. in order to assess how sensitive the internal anatomy is to slight variations in the patient's breath hold. We will then use that during planning to optimize the plan to be robust if need be. I'll describe this in more detail later. Okay, so the workflow begins from the patient's point of view with training, patient training. And this actually begins at home prior to the simulation. So for some time now, we've been making use of this online web tool that allows the patient to begin practicing with the SDX software at home before they come in for their simulation. So this is very beneficial, allows us to really be efficient and save time during simulation and treatment. We have had positive feedback from our sim therapy team that we've seen an improvement in patient compliance and things go more smoothly, and without the use of this tool, you spend some time during simulation getting the patient used to the main idea of what you're trying to do with breath hold, and also get familiar with the user interface. So this is a valuable tool that we make use of. Okay, for simulation, we start first just by assessing the patient's ability to tolerate breath hold. So not all patients can tolerate breath hold based on their breathing capacity, but also their disease, if they have disease in the lung. So this is really crucial because we don't want to start a patient on a plan with breath hold and then find out when we start treatment that in fact they can't tolerate it consistently and reproducibly. So this is a very important step. This is done first without the use of the video glasses. The patient practices breathing into the SDX device. And the goal here is that we're aiming for 3 stable breath holds of at least 20 seconds duration. Once we are confident the patient can tolerate breath hold, we will take the highest breath hold level of those 3 and then reduce it by 15%. So this is the moderate, in the moderate deep inhalation breath hold technique. So we're not actually imaging or treating the patient with their maximum breath hold. That would be not very stable, and so we avoid that. We use this moderate breath hold level. Then we move on to having the patient practice reaching this breath hold level using the video glasses. And then we take 3 breath hold scans, as I mentioned. So the nominal scan, the one which will be used for treatment planning, is 85% of the maximum breath hold level with a window of 0.02 liters. In addition to that, we take 2 other scans, other breath hold levels, high and a low scan, where the breath hold is equal to the nominal breath hold level plus and minus 100 milliliters with the same window. And again, this is to assess how much variation in the internal anatomy we see from variations in the patient's breath hold. And I'll come back to this later when we discuss treatment planning. But first, one interesting practice we've introduced here is that, and this is especially relevant to lymphoma. So I mentioned earlier, lymphoma, very often patients have disease that extends superiorly, even up into the neck. And so for treating this far up, it's really appropriate to use a head and neck mask. So in order to accommodate the use of the head and neck mask together with the SDX, we developed this stacked couch setup where we have a head and neck overlay, which you can see in the image there, which the mask attaches to, stacked on top of a body couch. And this allows space above the patient to place the SDX module. And then, of course, we also cut out a space in the mask to allow for the SDX nozzle. So this image here is just showing a picture of the setup. And on the right, you see just an image of the structure template that we've modeled in our planning system for this setup. So it includes, you can see here in turquoise, we have a special fiberglass index bar that we use for this setup so that we can avoid having high Z material in the plan, which could potentially lie in or near the beam path and can also generate some artifact, which would then need to be contoured and overridden and is time consuming. Okay. Pardon me. As with all proton treatment, because of the nature of proton systems, they're prone to have downtime. So we need to have a contingency in place. We need to have a backup photon treatment, which we do for all of our proton patients. So because we have been using the Varian RGSC system with our TrueBeam Linacs and the Varian RPM system with our Trilogy for all of our photon breath hold treatment. We use that system also for our backup photon treatment. What we do is we actually measure the baseline in both systems simultaneously in the same initial planning CT. So this is shown in the image on the bottom left. So you can see in the simulation the SDX on the far right, and the RGSC system on the left is the RGSC camera, and then the reflector cube is located on the patient's abdomen. So here we collect the baseline for both systems simultaneously corresponding to the same CT scan. So this allows quick and easy transition from one system to the other. There's one limitation when we are using the head and neck stack setup, because as you can see in the image, the patient is shifted down on the table. This means that depending on the height of the patient, it can make it difficult for the RGSC camera to pick up the signal from the reflector cube on the patient's abdomen. And in many cases, it's not possible. In that case, we can't baseline the two systems together, and we simply baseline the RGSC system at the first fraction of backup treatment if it's needed, using the CVCT and matching to the planning CT. And we've done this a number of times, and it's been very smooth without any issues. Okay, so now for treatment planning, the major feature of treatment planning that's different for breath hold is the option to optimize the plan using the high and low scans. So following the CT sim, a physicist is tasked with doing a motion evaluation to look at the 3 CT scans from sim and look at the displacement between the high and low and the nominal scans near the treatment site. And if the displacement exceeds 5 millimeters, in that case, we will use the high and low scans during optimization. So the planning system that we use is RayStation, and it has a tool where it allows us to actually, pardon me, optimize the plan simultaneously across 3 CT sets. So the nominal, of course, and then also the low and high scans. If the displacement between the 3 scans is less than 5 millimeters, we omit this robust optimization step. We can and do routinely look at robust evaluation on these additional scans, but we will not do robust optimization unless it's necessary. And the judgment is that if the motion is less than 5 millimeters, it's not necessary. Because of course, robustly optimizing across 3 scans will significantly increase the optimization time. And this robust optimization, of course, is in addition to the standard robust optimization criteria that are routinely used for all proton treatment plans, where we consider range and isocenter uncertainty. So if the high and low scans are used in optimization, it's important to make sure the 3 scans are fused correctly. That is, fused with matching done near the site of treatment, because of course that's where the patient will be matched with daily imaging for treatment. So dosimetry will break the auto registration between the 3 scans. They're all part of the same study, so they're auto registered. Break that auto registration and refuse the scans near the site of treatment. So this is an important step, and of course cross-check by physics. Another interesting and important feature for treatment planning of breath hold patients is that we want to do what we can to try and prevent an excessively long beam on time. That can be a strain for the patient to maintain breath hold for a very long time, particularly for large field size, like with lymphoma patients. Already, even without with such a large field size, the treatment time can be quite long. So to try and mitigate that, we limit the number of layers to 25. And we do this by editing the layer spacing scale parameter in RayStation to ensure that we not have too many layers, so that we can try and limit beam on time. So in principle, this puts a restriction on the optimizer and could affect homogeneity, but we've been able to optimize all of our plans well to have good coverage and homogeneity, even with this limitation. Okay, another important aspect of planning for breath hold patients, you have to take the SDX apparatus itself, and also patients are often treated with a wing board with elbows raised. So you have to take both the SDX mouthpiece and patient elbows into consideration for clearance check. So we plan on a 50 FOV scan, but we will also reconstruct a larger 80 cm extended field of view scan in order to contour these extra features and include them in the plan, so that we can check for clearance and ensure that we won't have any potential collision at treatment. So then with treatment, for setup and imaging, if the patient is using a head and neck mask, we will use the stacked couch setup. And we have, of course, a fixed indexing for our overlay that adheres to the structure template that's modeled in the planning system, so we can ensure we have everything correct as it should be. All of our lymphoma patients are imaged and treated with breath hold using the SDX. We do not have automatic control of imaging. So during imaging, the therapist will monitor the SDX screen visually, and also there is an audio alert, an alarm, which sounds whenever the patient's breathing signal leaves the breath hold. So this alerts the therapist to pause, interrupt the imaging. So we do, our standard is we start with an initial dual KV, followed by CBCT and one final dual KV. As is standard in many proton centers, we always do one final set of KVs following any shift. And we have the capability to pause and resume our CBCT when necessary, and this is crucial for breath hold patients, as often the CBCT will need to be acquired in 2 acquisitions because of the breath hold. So we have the ability to do this without having to repeat the CBCT from the start. And so on the right, we see just an example of one of our lymphoma patients, the daily imaging matched the planning CT. You can see this is imaged under breath hold, and you can see we have good agreement near the region of the target. Treatment. I mentioned earlier we have automatic beam control. So any plan that comes from our treatment planning system has breath hold, specifically SDX breath hold, switch turned on in the planning system, which attaches a DICOM tag to the plan file, such that when it arrives at the treatment console, it is expecting to see an input gating signal and will not beam on without this input signal. You can see the console on the bottom left where we select SDX as the input signal. So without selecting this, the system cannot beam on. So when we treat, the breath hold window that we use is equal to the nominal breath hold level that was established at SIM. And this is an important point. The window that we use is 50 milliliters, plus or minus 50 milliliters. So the reason this is important is because this is tighter by a factor of 2, or 1/2, than the difference between the high and low scans, which was 100 milliliters, used for robust optimization. So in doing this, we're ensuring that the patient will not be treated outside of the range in which we know the plan is robust. So once treatment begins, of course, we have regular verification scans that are carried out routinely throughout the patient's treatment. The frequency will depend on the treatment site and the anatomy, and is specified by the physician at the start of treatment. After each QACT, the plan dose is recalculated on the QACT, and an evaluation is done, which looks at robust target coverage, which is based on the criteria of 95% of the prescription, covering 95% of the target. This is looser, of course, than our nominal target coverage for the plan on the planning CT. But this is the robust target coverage that we use in evaluating our QACTs. And a recommendation is made by dosimetry and physics to the physician, who makes a final decision on whether or not a plan is needed, a replan. And this is just an example of one of our QACT evaluations. On the top left, you see the plan on the original planning CT. The bottom left is the evaluation on the QACT. And we see an overlay of DVHs showing that the dose is quite similar, very stable. And on the bottom right, we have our clinical goals, showing that everything is met for this QACT. So in this case, no plan revision was needed. Okay, I'm going to walk through the quality assurance. So quality assurance is carried out every day that the SDX system is used. We use the MyQA software, which is put out by IBA. There's a screen capture here showing the different tests that are run. It is run by the therapists in the morning who are trained by the physics team, and then checked and signed off on by physics for treatment. It consists of 3 components, essentially. We have spirometer calibration check, followed by a test of various beam interlocks. And then finally, we run a test plan to test the gated beam delivery and actually verify this with an independent dose measurement. So I'll walk through those one by one now. So first, the spirometer calibration check. So this is done essentially just to verify that the spirometer signal, which is calibrated to changing lung volume, change in lung volume, is stable, it's still accurate. So the calibration and the calibration check is done using this syringe, which is shown on the left. So this is a syringe of a fixed volume of 3 liters. And so we use this to cross-check the calibration every day that the SDX is used. And the requirement is that the inspiratory volume and expiratory volume are within 2% of the baseline values. And this is actually interlocked by the SDX system so that you will not be able to use the SDX system without running this calibration check within, I believe, a 24-hour period. So we test, of course, various beam interlocks. So the first interlock that you see on the left, this is an error which appears in our IBA Proton system, which tells us anytime a breath hold plan is loaded, if there is no input breath hold signal, which I showed earlier, selected on the console, we get this error and we can't proceed. So we test that and make sure that that's still active. And then after selecting the input signal,
I have a question.
Sure.
Excuse me. Can you might ask you to tie the question we say for the speaker to finish first?
Sure.
Thank you.
Sure.
Thank you.
Sure. Thank you.
No problem. Thanks very much. And so in addition to that, after selecting the input signal, we verify that when beaming on, when pressing beam on, the beam will be held, as you see on the right, when the input signal is not within the breath hold window. And so beam on doesn't occur until you reach the breath hold window. We also check, of course, the functioning of the video goggles. And the final check is actually to deliver a test plan to an array detector. We use a matrix PT. And here we will deliver the beam with a beam interruption. So we will force the breath hold signal to leave the breath hold band. Verify that the beam is interrupted, which is perhaps the most important interlock, and then return to the band. And we use the independent measurement to verify that the full beam is delivered, even with the interruption. So this is all done on a daily basis, and we record the results in our MyQA system and sign off on it. And we've had no issues with our daily QA. no failed tests that could not be resolved. So it's quite reliable. Okay, so just an overview of our experience with breath hold for our Proton patients at Inova. So to date, we've treated 11 patients with the SDX, and this is the breakdown of the different treatment sites. So you can see the leading treatment site is actually lymphoma, which was really the motivation for focusing on lymphoma in this talk. And we've also treated a smattering of other sites: lung, liver, esophagus, pancreas. So our experience with the SDX has been overall very positive. So I mentioned earlier the ability we have to do robust optimization using the high and low breath hold scans. It's a key part of our workflow. But as it happens, to date, we have not had to use this. So in all cases that we've had, the difference between the high and low scans and the nominal scan is less than 5 millimeters. So this is actually showing that for most patients, all the patients that we've seen so far, the internal anatomy is not very sensitive to slight variations in the breath hold signal, which is of course a good thing. It makes the use of SDX more robust. Despite that, we have this feature built into our workflow so that we can account for it if and when we encounter patients where the internal anatomy is more sensitive to the breath hold position. We had only one planned revision for a breath hold patient. It was due to unstable anatomy. It was unrelated to the breath hold. It was just a change in anatomy. So not caused by any issue with the breath hold technique or the system. And we had just one patient transition to their backup photon treatment. This was due to issue with the Proton system that led to downtime. Again, not related to breath hold. Okay, now for lymphoma patients. So our setup is, I mentioned earlier, we treat all of our lymphoma patients with breath hold using the SDX. Initially, we were not using the mask setup. We were using just a wing board with a back lock. More recently, we introduced the use of this 5-point head and neck mask with the stacked couch setup that I described earlier. And so far, we've treated, I believe, 3 patients with this setup. And it's gone very smoothly. We've seen great alignment and treatment. For planning, we generally use a prescription of 150 times 14 for 21 gray for pediatrics. And we may use a larger, higher prescription for adults. Here's just an overview of the clinical goals that we're using in planning. These goals here are taken from the ILRG guidelines that I referenced earlier. So this is actually not a comprehensive list of all of the clinical goals that we use internally, but these are included. So these are a subset of what we use. So we, of course, try to limit dose to the heart, breast, lung, and thyroid. So for planning, in most situations, actually in 4 out of 5 of the lymphoma patients that we've had, we use a single anterior field, which uses, of course, SFO, just a single field. So this works very well in the majority of cases and has the benefits I mentioned earlier. Single field reduces treatment time, and you don't have to worry about field matching, which adds some complexity. So we had one case which was slightly more complex, which involved a multi-field arrangement and utilized an MFO, or multi-field optimization. So I'll describe that in more detail now. But just first, briefly, I just wanted to cite this publication just to emphasize, I said this earlier, because of the high percent of pediatrics who suffer from lymphoma, the secondary cancers is actually the leading cause of death among long-term survivors of Hodgkin's lymphoma. So this has to be prioritized in treatment planning. In particular, I cite the study here that shows an increased risk of breast cancer for patients 1 year out, female survivors who are diagnosed less than 30 years old. So this risk increases with decreasing age. So for younger patients, it's more significant. So the takeaway message here is that sparing breast tissue is really important, particularly for pediatric lymphoma patients. So with that in mind, this patient here we treated, this was a 16-year-old female with Hodgkin's lymphoma, had widespread disease, which was visible on PET, and it was not confined to the mediastinum, but extended up superiorly into the neck. And so, one, we wanted to immobilize the head and neck well, together with SDX. So this was one of the patients that we treated with our stacked couch configuration. And we also wanted to have robust coverage of the lymph nodes in the neck while avoiding the SDX. You can see the mouthpiece. You may think that the mouthpiece of the SDX would present a challenge or an obstacle, or make it difficult to treat the lymph nodes in the neck. But in fact, it can be treated effectively just by using a slightly more complicated or more advanced beam configuration, which I'll describe. And another goal, of course, which I just emphasized, was sparing of breast tissue due to the patient's age. So the plan that we ended up with was, instead of a single AP field, we used a 3-field MFO plan that made use of an AP field and 2 anterior oblique fields. So you can get a sense of the configuration in the 3D graphic shown on the right. So we have an AP field more inferiorly to treat the mediastinal disease. And more superiorly, we have these 2 anterior oblique fields, which allows us to treat the neck while avoiding the mouthpiece of the SDX apparatus. And it's important, of course. So here we have a multi-field plan, so we have to ensure it's robust. So we need to concern ourselves with the interface between these fields, right? We need to match the fields well to ensure that we have homogeneous dose within the target and it's robust. So with MFO, we can do this very easily just by doing a gradient match. So you can see that here in these images. So on the far left column, this is the full plan. And in the middle column, this is showing the dose from the anterior oblique, specifically the left anterior oblique field. And on the far right, you see the dose just from the anterior field. So you can see in these images that we have a gradual fall off in dose from each of the fields taken independently. And this is done intentionally in planning in order to make the plan robust to potential shifts if the patient were to move between fields. So this makes the plan very robust. You can see the overlap region on the bottom right, and the contribution from each field. So actually, we have gradient matching in several directions, in the sup-inf direction, and also in the right-left direction, in order to ensure good coverage. Now, you may ask, why not simply treat, if the goal is to avoid the SDX apparatus, we could accomplish that with a two-field plan, just two anterior oblique fields. So we considered that, but ultimately decided on the three-field plan. And the motivation, again, of course, is the desire to limit dose to the breast tissue. So that can be seen here. We have the final plan that was delivered on the top left, and on the bottom left, this is the two-field plan with the difference shown on the bottom right. And so you can see we were able to significantly cool down the breast tissue with this field configuration. So of course, the trade-off there is that we get some higher dose in the mediastinum, in the lung and mediastinum. And so the clinical judgment that was relied on there, that ultimately made us select the three-field plan, was that with lymphoma, the prescription is relatively low. So the dose to structures in the mediastinum, such as the trachea and esophagus, is a secondary consideration to the desire to limit dose to the breast, because of the patient's young age and the potential risk of secondary malignancies. So that was a trade-off that was made. Okay, just some imaging showing that this patient, the treatment went very smoothly. Patient achieved breath hold easily and reliably throughout treatment with the SDX. Imaging showed very good matching of anatomy, and it was very efficient. So the setup, imaging, and treatment went quickly, and the treatment time was comparable to the normal free breathing treatment. No delays caused by breath hold. And verification scans carried out for this patient. There were 2 verification scans taken, and in each case, the anatomy was very stable, and the dose evaluation showed very little deviation, and so no planned revision was deemed necessary. And just one final point on patient experience, discussing the patient with the physician, Dr. Rao. Patients experienced some mild esophagitis, but nothing very severe. Esophagitis, I believe, is typical for treatment of lymphoma. And we think limiting the dose to the breast tissue was really beneficial. Okay, so in conclusion, proton therapy certainly can be very beneficial for treating lymphoma patients. The IVH in particular allows even greater sparing of the nearby normal tissue. It allows us to avoid using internal margins with an ITV technique, so we can limit the high dose, make it more conformal to the target. Spirometer-based systems such as the SDX are ideal for proton therapy, as in principle, there is a greater or stronger correlation between the spirometer signal and internal tumor motion, as compared with some other systems which rely on external markers. And our experience at Inova has been very positive using SDX for all of our breath hold patients, and in particular lymphoma. And we were pleased to see we were able to treat this patient that we highlighted with SDX and still cover the disease well. We've had good patient compliance, no major issues with patients having difficulty getting through their treatment. And all daily imaging and verification scans show that the breath hold, anatomy under breath hold is quite reproducible. So with that, just mention a few references and thank DYN'R for the opportunity to share our experience, and thank the whole Inova team, very large team, and everyone works very hard, does a great job. And special thanks to a number of people, Dr. Pong and Dr. Rao for helping put this talk together, and also a number of people listed here. Thanks very much.
Wow, thank you, Dr. Finn O'Reilly. This is an excellent presentation, and we have thank